Ladies and gentlemen, sorry for the delay, and welcome to Brain Health Awareness Week. Thank you all for being here for our second annual Brain Health Awareness Week presented by the University of Ottawa Brain and Mind Research Institute in conjunction with the City of Ottawa. So this week is very special for us. It's an opportunity to engage with you and highlight exciting progress within the brain and mind. I think today you're in for a great treat. Just a few of our best scientists and clinicians will tell you about our new ideas and advances in PD research, and of course highlight what we're doing for PD patients today to improve your quality of life. We have some amazing brain research in Ottawa. And let me tell you a little bit about how we've started to organize it in terms of the brain and mind. So the Brain and Mind Research Institute was set up to take advantage of the expertise in brain research in the Ottawa area and coordinate between 5 academic hospitals, 6 different faculties within uOttawa and of course Carleton University to tackle very difficult problems of brain disorders such as PD. PD is our first priority and talk of the week. I want to say that the Brain and Mind is a very unique initiative worldwide, putting together more than 200 talented, multidisciplinary researchers working together in unique ways to come up with new solutions and understanding to the intractable problems of brain disorders of a variety of types. Now, I do want to mention very briefly that an important part of the effort of the uOBMRI is to connect with you, the community, because quite frankly, we serve your needs. And as part of this outreach, we inform the public through this annual Brain Health Awareness Week. It ends, there's many other days with stroke, PTSD, neuromuscular, stem cell debate on Friday, but it ends with a fundraising yoga event on Saturday on Tabaret Hall, right across the street there, 8:30 in the morning starting this Saturday, and I invite all of you to join us and celebrate and support the University of Ottawa Brain and Mind Research Institute. And finally, I just want to briefly mention that we also have the Ambassador Program. And the Ambassador Program helps us connect with you throughout the year. Our ambassadors are our biggest supporters who help us spread awareness and raise money to support the amazing things happening in research and in PD research that you're going to be talking about and listening to today. So please join us for Yoga and You. Please support us. We thank you for being here. And so without further ado, on with the program. So I'd like to begin this afternoon by introducing today's MC, Terry Marcotte, who needs really no introduction. He is the sports director of CTV Ottawa, having been at CTV since 1987, Ottawa native with a large number of awards and 3 decades on air. He's also served on our Parkinson's Research Consortium board. And for those of you who may be a little confused, the Parkinson's Research Consortium is now under the Brain and Mind. It's all one and the same. So he's been part of this board for several years, one of our biggest supporters. Terry, thank you so much for generously volunteering to host our afternoon meeting.
Thank you very much. And I apologize, I think one of the reasons why it's running a little bit late, I went to the wrong hall. I ended up, you don't want to know where. It's a pleasure again to be here and to see so many familiar faces. And I've been involved, as David said, with Parkinson's for some time. My father had Parkinson's, and I saw what the disease does. And I look at today as a day of, I'm going to bring this up a little bit, as a day of hope. And what we're seeing, my dad passed away in 1990, to give you a little bit of a time frame, and the changes since then are incredible, and it's exciting to see the changes, and you're going to hear a lot of what's going on, a lot of what's going on in Ottawa too, and Ottawa has become a leader in dealing with Parkinson's. So I'd like to welcome everyone here, doctors, patients, scientists. Thanks for coming out to Progress in Motion, integrating Parkinson's care as part of Brain Health Awareness Week, and thank you for coming out. We'd like to start off now. I'd like to introduce a couple of people. Dr. Michael Schlossmacher first, Professor of Medicine, Neurology at the University of Ottawa. He's a research chair in neurodegeneration at the Ottawa Hospital and Director of Neuroscience Program at the Ottawa Hospital Research Institute. And Dr. Adam Sachs, the Director of Neuromodulation and Functional Neurosurgery at the Ottawa Hospital, Assistant Professor of Surgery in the Division of Neurosurgery, and Adjunct Professor of Philosophy at McGill University. You can see they haven't done much with their lives, but they're going to talk to us about new developments in Parkinson's disease and treatment and research, and focusing on some of the positives that we were talking about. So doctors, take it away.
My name is Michael Schlossmacher, and because of technical challenges, I go first before Adam, and our neurosurgeon. So I was endowed, I was asked to talk about two topics today in Parkinson's disease. One, to provide you with an update on clinical trials, and then also a little bit of an update on scientific progress. And I wanted to thank you all for coming. This is a wonderful opportunity. This is the second year where the Brain Health Awareness Week takes place. So I've named this presentation Update in Parkinson's Disease, Trials and Fibrillations. To make fun of the term trials and tribulations, but also because I wanted to update you, as I said, on clinical trials and also on the topic of fibril formation. Fibrils have become a really important topic in the field of Parkinson's disease, Alzheimer's, as well as related disorders such as amyotrophic lateral sclerosis, which is Lou Gehrig's disease. But the first point that I wanted to convey to you is that despite the many setbacks that we've had over the last few years with respect to clinical trials in Parkinson's disease, and many of you in the audience have participated in them, there's actually some wonderful news to report that just came out over the last 10 days. And if we get the slide to display it, the study that came out and was communicated to us through the Parkinson's Disease Foundation in the United States, through the Michael J. Fox Foundation, as well as the Parkinson's Society of Canada and the NIH, is the next, thank you. So this is the first part, the clinical trials that have to be reviewed. The wonderful news that have reached us is about the Innocent trial. This is a drug that was invented or thought of by one of my former colleagues, Michael Schwarzschild. And you may have heard of this uric acid or urate before, for those of you who are unfortunate enough to suffer from gout or know people who suffer from gout. When we have too much of this in our bloodstream, then we're prone to develop a very, very painful inflammatory condition of our joints. It's called gout. And the interesting observation that Michael Schwarzschild's team made in Boston a number of years ago is that those patients with Parkinson's disease who have higher levels, they don't necessarily have gout, full-blown gout, but when they have higher levels in their bloodstream of uric acid, they had a slower progression of their Parkinson's disease from one stage to the next. So he had the great idea of thinking, well, if you have too much uric acid, you get gout, but what if we elevate it just a little bit? In those people who have a low level, can we slow down Parkinson's disease? And so he went through a number of studies to prove that first in patients that have donated blood many years ago, and could first prove that indeed those people with the highest amount of uric acid had the lowest rate of progression. And this study then was turned around, flipped around, to use a drug that's called Innocent to elevate, slightly elevate the level, so not to drive people into gout attacks, but to potentially slow their rate of progression. And this was initially started at the Massachusetts General Hospital. Subsequently, a so-called phase 2 study was supported by the Michael J. Fox Foundation. This was their announcement, and they invested $5.6 million in a multi-center phase 2 trial to show that elevating uric acid was, number one, safe, and indeed could slow down the rate of Parkinson's disease progression. Now, that hasn't been widely published. It was just released through the funding agency, the Michael J. Fox Foundation, and the NIH, that this was successful. In other words, there's a steering committee that looks at the data as it evolves in real time, and they found that there was a benefit, and therefore helped convince Michael Schwarzschild and his colleagues, helped convince the NIH and its National Institute of Neurological Disorders to fund the next step, which is involving thousands of patients in multiple centers around the world, including in the United States and in Canada. And the planning stage of this trial is now underway, and it's to give people innocent to see whether this would be possible at a larger scale to slow down the rate of Parkinson's disease. So this is really exciting because many of you who have participated in trials have been disappointed. A lot of hype, this might work, and then we came to realize in carefully conducted studies that an intervention hasn't worked, and money was spent without finding a breakthrough. So this is promising. The second thing I wanted to update you on, going back to what other trials are taking place, is a presentation that generated a lot of buzz around the world in Nice, France, at the Alzheimer's and Parkinson's disease meeting. It just took place in March. And a group of scientists based at Biogen, a company in Cambridge, Massachusetts, that has a primary focus on multiple sclerosis, but retooled their efforts to also come up with ideas for Alzheimer's and Parkinson's, presented a phase 2A trial in which they demonstrated that in a group of 100 patients with Alzheimer's, their intervention, which was a passive vaccine where antibodies are delivered, so from an octogenarian, from an 80-year-old patient who was healthy, they isolated antibodies, made them renewable in the laboratory, and then basically infused them in people with Alzheimer's disease. And this antibody was directed against the bad player of Alzheimer's, it's amyloid plaque buildup. And what they've shown in their release of information, that in the highest group, they could slow down Alzheimer's progression. And that's, again, just the first step. 100 people so far, has not been widely published, but people who bought shares of Biogen saw their shares triple or quadruple because of the excitement it generated. And now they are going to raise money from investors to do a phase 3. Why is this important to Parkinson's? Because the same approach was applied to the study of Parkinson's disease in preclinical models. In other words, in mice and in monkeys, to test whether a similar approach, passive vaccination, may work for Parkinson's disease. And a number of Canadian scientists, including myself, were asked to comment for this company as to how this could be done. In Parkinson's, as many of you know, there's a buildup of not amyloid like in Alzheimer's, but synuclein, and people like Andrew Frank even know how to pronounce alpha-synuclein. It's a tongue breaker sometimes, but here you can see everything that's brown is an abnormal buildup of this protein. And so the purpose of what Biogen is trying to do is to come up with a vaccination or a clinical intervention by which this buildup is being reduced to see whether it could help slow down the illness. And the people who discovered this buildup, this is a human brain cut in slices, different stages of Parkinson's disease, early on and more advanced. And when it's high up in the cortex, like here, this is where we make decisions and where we make judgments and have insights, and this is generally where executive function is located. This underlies some of the cognitive problems that our patients have with Parkinson's disease. Kelly Del Tredici and her husband, Heiko Brock, discovered this buildup, and one of the things that many people are doing around the world is to understand how these fibrils, hence the title fibrillization, propagated. And of note is also that Ottawa teams of researchers did a very good job in Nice to present their research. However, companies in the United States are not the only ones that do good work. There's also two efforts that are going on currently in Canada. One is NeuroConnects, that's a company based in PEI that has an annual meeting and has presented its project going into a phase 1 trial. and Dr. Robertson, who's going to come and visit us at the end of this year, he will talk about it. Another thing that's going on, some of you may have heard that there's a very strong genetic link between Parkinson's disease and Gaucher disease. A company that has products, namely Shira, another one is Genzyme, for this illness, is currently planning a meeting here in Ottawa with patients and caregivers to see whether some of the drugs that work in this illness, which is a rare illness affecting liver and spleen and bone marrow, may actually be what's called repositioned, so that drugs that are approved for one disease may be tried out in another disease. And so this meeting took place, the first one in Amsterdam to plan this, and the second one will be related to this meeting in Ottawa. So this is exciting that Canadians are pursuing such clinical trial planning steps as well. And hopefully not only will Canadians be part of this, but also our center here in Ottawa will be part of these trials. And Dr. Grimes will talk about this. So the second word was fibrillization. It's related to this protein synuclein. And I showed you previously that this was first discovered in the brain, and this is the bad buildup. Now, why is this fibril formation so important? It's also a potential target to treat Parkinson's in the future. Why? Because not only does it build up in the disease as it progresses from this stage to this one, but when one looks, this is just with the naked eye, but this is seen with a microscope, this spread of fibrils that are made of synuclein also happen in patients that received transplants, fetal transplants. So when they, after their transplants that in and by themselves were not successful to stop Parkinson's disease, but when they came to autopsy because of a car accident or something else after they had received the transplant and lived for less than 10 years, there was no abnormality seen. But when they came to autopsy, this is normally what the recipient of these cells looks like. They have a lot of abnormal cells to begin with because of Parkinson's disease. These are single cells here, that a ton of this makes this brown. But interesting enough, when the patients lived for more than 10 years after the transplant, the cells that were given to them as new cells contracted the disease, if you will, as well. So it jumped from the graft to from the host, namely the recipient, to the grafted cells, which made people think, such as Dr. Cordova, that this disease may, in part, move forward by jumping for the abnormal aggregates, fibrils of synuclein, to jump from one cell to the other. So this gave enormous research impetus for a number of centers around the world to study this in mouse models. This is the brain of a mouse. So the third thing that you often heard me and others say is that we need better markers in fluids, in biological fluids, such as your blood, or plasma, serum, or spinal fluid. And so we need those because we need to find out who has Parkinson's, who progresses at what rate or gets better with a clinical trial, and can we predict what happens to people? That's often referred to as excuse me, state, rate, and fate of an illness. And in particular, so many of our patients that have Parkinson's are affected potentially by cognitive problems. And I'm almost done. So the last scientific news that I wanted to show you is that just hot off the press from last week. And it summarizes a lot of work from multiple centers over multiple years. And because it's so novel, it also took 2.5 years to publish because people didn't want to believe the story. But this is 3 different tests. And what's important here is blue is Parkinson's and gray is normal. And there's a slight discrepancy between the levels of a particular form of this alpha-synuclein in our blood. So in other words, we were looking in the blood what might be going on in the brain. And there's a reduction in this marker, not very robust, not separating it completely, but partially. But importantly, when we looked at this blood marker, we could tell that when we followed people in 3 different cohorts that we founded in North America, that over 5 years, the people who had the lowest value, like here or here or here, had the fastest and best prediction of cognitive decline. So they lost some of their executive function. And so if we hone in and basically focus on this, we may actually turn this around in day 1 to be able to predict what happens to that person in 5 years, something we desperately need as well. And then lastly, I wanted to say that there's also, for those people who have a very rare cousin of Parkinson's called multiple system atrophy, there's a lot going on as well around the world with coalitions forming. to try to do similar things, to develop markers and to develop new targets so that we can come up with clinical trials eventually. Thank you for your attention, and I'm deeply indebted to our patients, our nurses, caregivers, team members, scientists, everybody who helps move these things forward. Thank you very much. Okay, our next speaker, and we have a question and answer session at the end. I know there's always a number of questions on these topics. Our next speaker is Dr. Adam Sachs, a wonderful colleague from the Division of Neurosurgery.
Thank you, Michael. I'm a neurosurgeon, and I'll be talking today about surgical management of Parkinson's disease and the new deep brain stimulation program in Ottawa, and also some research that we have started that's emerged from that program. Deep brain stimulation is a treatment that treats the brain as a system that creates smooth movements based on a network of different nodes. And those nodes behave in an aberrant fashion in Parkinson's disease because of decreased dopamine production and substantia nigra. There's fallout distally to that, and therefore there's aberrant behavior in that network that results in these cardinal motor symptoms of Parkinson's disease. And deep brain stimulation involves surgical implantation of electrodes to specific targets within that network to attempt to restore the normal physiology to some degree and improve the symptoms of Parkinson's disease. So this is a typical patient with Parkinson's disease. His brain on imaging would look like a normal brain, but the physiology is abnormal. And the target for deep brain stimulation is about 1/4 of a cc, 1/4 of a cubic centimeter. It's a subthalamic nucleus. And the job of the neurosurgeon, my job in the operating room, is to place the electrode with that degree of precision into the brain. And we do it in 2 different stages. The first stage is imaging and using preoperative MRI and navigation to bring the electrode close to the target, and then we refine it using physiological recordings. So this is an MRI that was used for the planning of a deep brain stimulation surgery, and we changed it to a color map for technical reasons. In the operating room, we're able to register the patient's head in real time with the imaging that was taken beforehand. And because we're able to have that real-time registration using an optical navigation system, we're able to direct the electrodes to the location within submillimetric accuracy based on imaging alone. The second stage of it is the placement of electrodes. So this is also an intraoperative photograph showing a micro drive. In this case, it's a disposable micro drive because we use a frameless technique. These patients, in order to have that physiological refinement by recording from the brain, the patients are awake so that they can participate in the examination and provide feedback to us. So for comfort purposes, we have a system where they're able to move their neck. And this is the type of recordings that we see in the operating room. We actually are able to listen with earphones to the cells in the brain and identify the target based on the chatter of those cells in the brain. And when we're not in the correct location, we're able to refine that location with movements in one direction or another to hit the most optimal location as far as we can tell surgically. So this is a movie in surgery of a patient who has the electrode already placed in the correct location. And this is a good video because one of his main symptoms of his disease was tremor. And that's what happened when we turned the stimulator on. So a very dramatic response, and you're able to see almost immediate cessation of tremor. In other cases where different motor symptoms predominate, you also have relatively impressive results. Of course, you don't see rigidity disappear in the operating room, but we do post-operatively. And after surgery, these patients go on for months of programming and neurological assessments by the neurologist in the program, Dr. Mestre. So this is, without telling him, we turned the stimulator off And so you can see his smile start to disappear as the tremor reemerges. So we thought we would do a bit of a blinded assessment in the operating room. So based on this clinical surgical program, we felt that we had an opportunity to investigate some aspects of Parkinson's disease therapy. And specifically, we have awake patients with Parkinson's disease with electrodes in the brain, and those patients who choose to participate in research can enroll in this research program that we have. The goal of the program is, one, to try to understand the physiology of the target, in this case the subthalamic nucleus, better, with the hopes of allowing for a next generation of neuromodulation, a next generation of deep brain stimulation surgery, which is better able to harness our better known physiology of these targets. So one of the goals was, we know that certain types of electrophysiology in the subthalamic nucleus give rise to symptoms of Parkinson's disease. We know that the cells are tuned to movement, so they respond when people move. But we don't know exactly how they're tuned to movement, and we don't know specifically if they're tuned to one direction versus another. So we wanted to ask the question, can we decode participants' movement by looking at the recordings alone? Can we tell which movement they were intending to look at? And then as a second layer of complexity, we wanted to know, is this a visual or is this based on proprioception? And so to answer these questions, we used a virtual reality environment where patients have a virtual representation of their hand, and in order to discriminate between the visual system and the proprioception, we're able to manipulate that virtual reality environment. So that's question number one. Question number two, we wanted to know, we know that there are certain electrophysiological signatures in the brain that correspond to the Parkinsonian state. And our question was, if we're recording and somebody is conscious and they have some kind of feedback, is it possible for people to control the state of their brain and perhaps in doing so reduce the symptoms of the Parkinson's disease? And can using visual feedback in real time allow people to self-improve, to improve their symptoms? So that's the goal of these research program. It's a very new research program, but I'll show some pilots, some initial results. So I summarized those aims in this slide. The methods are using the virtual reality goggles and doing a task where initially participants wear the virtual reality goggles, there's a hand tracker, and then move the hand in the directions that we ask them to. And then offline, we attempt to decode, but from the neural recordings, what direction we're moving. And then we do that with reversing the direction on the virtual reality. So this is what they see visually. They see that central sphere represents their hand. There's a hand tracker, and there's a left eye, right eye. But of course, from their perception, they just see one of these. And then we tell them which target to move their hand to. This is a photograph in surgery of a participant performing this experiment where the virtual reality goggles and the hand is being tracked while performing that experiment. This is the type of data that would emerge from that kind of experiment. So in the upper left corner, panel A, there's the raw brain recordings. And in panel B and C, we looked at the different directions, and we attempted to cluster them by looking at certain electrophysiological features. We attempt to cluster them in space and then to try to group them. And that's what we see in the bottom right. And what we found was that there was some degree of decoding that we were able to do of the intended direction from the recordings alone, and that ability to decode increased with the number of electrodes. So that's what we found so far. So it's a promising result that one can get a highly precise prediction of movement from the recordings of the target in deep brain stimulation. What our hope is that in the future we'll be able to use this to refine deep brain stimulation further. The second experiment, this is data from an actual participant. He's being instructed, turn this sphere, this color, by controlling your brain. So when we say blue, think of yourself as being calm, not Parkinsonian, being able to move. Think of how you were beforehand. And when we instruct orange, think of yourself rigid, frozen. And so participants, what we found, we've only done this twice now, so this is very initial results, but what we found was for the first 15 or 20 trials, it was essentially random as the participant learned some internal neural strategies for performing the task. And then what we found in the later trials was that there was pretty good performance in this task, and people were able to control what we know to be electrophysiological biomarkers of Parkinson's disease. They were able to increase them, decrease them on demand using this color cue as the cue for control, and using the virtual reality to get the biofeedback. So this is a summary of data from that session, and what you can see in the top panel and the top two panels show the average overall trials. And what you can see is that there's a very clear difference in the activity of the brain when they're instructed to think of the color blue versus when they're instructed to think of the color orange. And remember that what we're doing when they're being instructed to do that is modifying the color based on how Parkinsonian the recordings are. And so the patient's controlling the state that we believe to be related to the Parkinson's state. And at the bottom figure, we can see that over the first 15 trials or so, over the first 15 trials or so, there's essentially no difference, but from roughly trial 15 to trial 30, differences emerged between these two states, and there were a lot more reliable differences. So this gives us hope. Now the next step, of course, is to see if this actually improves their symptoms. So what we know now is that people can control the waves that, the brain waves that we're recording from when they're presented with some kind of representation of that brain wave in real time. We've established that in 2 patients. We haven't established it statistically or clinically. And then the next thing to test is, does reaction time improve? Does accuracy improve? Does smoothness improve? And so these are the things that we'll be testing in the near future as part of this research program. In summary, we have a new surgical program and neurological program at the Ottawa Hospital, which is Deep Brain Stimulation Program, started in December of 2013. We've conducted the surgery on 19 patients so far and have also started a research program around this. What we found in that research program preliminarily is that neurons in the target nucleus, the subthalamic nucleus, may predict activity onset and movement direction, and that people may be able to acquire voluntary control over the amount of beta activity, which is that biomarker, that electrophysiological biomarker of the Parkinson's state, and synchrony of the subthalamic nucleus. Before signing off, I just also wanted to thank my postdoctoral fellow who's not here right now, Dr. Chad Boulay, for his excellent work in these experiments. Thank you.
So a lot of exciting things going on, and this is another exciting part of the program where we honor some of the next generation of researchers, and 4 young scientists all are working on Parkinson's-related projects, and they've been awarded PRC fellowships for the 2015-2016 academic year. And I'd like to invite up now B. Robertson, representing the Audrey Grant Parkinson's Research Fellowship, and she will present a certificate to Jacqueline Takaru, a graduate student from the lab of Dr. Schlossmacher. Hello, B.
So, unfortunately, none of you are going to get to see my really nice slides. And I'll try to yell as much as I can. I wanted to just remind people if they had any questions about Piper, so Andrew's going to be at the back too. So if you want to get involved in either of the things that we're trying to raise funds for, please talk to Andrew or to Natasha. So I'm up here. I'm going to just talk a little bit about our integrated care network that we've put together, and the idea was that, as you all know, we don't fully understand what causes Parkinson's disease. There's a lot of complicated pathways involved. There's a lot of work being done to try to understand those pathways and therefore trying to come up with treatments that really affect the progression of Parkinson's. But as we don't have those treatments at this point in time, I think we still need to do a better job of the care that we deliver to our patients. And so we know that Parkinson's is not just slowness or stiffness or tremor. We know that people with Parkinson's have lots of other difficulties, and those difficulties are ones that are harder to address with our standard Parkinson medications. And so these, what we call the non-motor symptoms of Parkinson's, so whether it's blood pressure issues, whether it's bladder or bowel issues, whether it's cognitive issues, these are all things that we need to do a better job with treating if we don't have a cure at this point. So if we were very much involved in the development of the Canadian guidelines for treating Parkinson's disease, and if you look through the recommendations that we put together, we have a lot of different recommendations that talk about these issues, and that we don't have enough things that we've done for people, I think, in this area. So if you look through some of them, I've listed out, I would have shown you on the slides that, I mean, we have one of the recommendations about making sure we give important information, making sure that we develop care plans for people, making sure there's an accessibility contact for people, and make sure that people have regular access to not only physicians, but also the nurses or other individuals within the clinic. We did come out with a statement that we got a lot of trouble from a lot of different sources when we also suggested that the idea of home visits for people with Parkinson's. I think, unfortunately, we're still a ways from that, but I think ideally that's something that we would like to explore as we grow our services. The other things we talked about in the guidelines was the idea that you know, an important part of the management of Parkinson's is physiotherapy, occupational therapy, and accessibility for these things. And I think I felt in the clinic, and I know my colleagues did, in terms of we try to make suggestions, but there's so many suggestions out there, I think we're not doing a good enough job in that area. And this is one of the focuses. The other part is the idea of speech and language and swallowing difficulties, and in the guidelines we try to reinforce that these are important things that need to be looked at, and in the short clinic visits that people have, we can't address all of these issues. Has this kind of thing been tried before in Ontario? And the answer is yes. So one of my colleagues, Dr. Mark Gutman, ran for quite a few years a specialty clinic where they did have physiotherapy, they did have an occupational therapist, they had a social worker attached to it, they had some links to the CCAC. And so he actually did a randomized trial where 50 patients got a referral, and the referrals went to a general neurologist, and then 50 referrals went to his clinic. And so they had standard assessments done in terms of looking at quality of life. They had standard assessments done looking at sort of how people were in terms of their overall functioning with their Parkinson's. And with this study, he was able to show that people who came to a specialty clinic actually did better, and when they had these extra services. Now, as part of the study, the only things they had in addition were seeing the specialist was a nurse, a Parkinson's nurse, and a social worker. So those are the only extra services, and even with those, adding those extra parts to the care, they were able to show in this randomized study that there was benefit. The trouble is that the Ontario government really has no interest in funding that model of care, and they actually cut the money to this clinic just outside of Toronto. And so from a practical standpoint, although that's maybe what we'd all like to see, it's just not possible. And so we had to think of a different way to try to look at delivering care within the confines of where we were functioning in Ontario. So this is where we came up with our idea of this integrated Parkinson Care Network. And the idea behind the network is, you can see we're doing a lot of research. We have basic research going on. We have fellowships that we fund. We have students working in the lab. We have a clinical trials program that we run. We're starting a biomarkers part of this. So we have half of what we're trying to do is on the research side, and then we have the clinical care side of things that we need to do a better job. And so the idea is, if the center part of this whole idea revolved around a care coordinator. And the idea that we needed a care coordinator who could bridge the research half of what we were trying to do and the clinical half of what we were going to do. And we didn't have hundreds of thousands of dollars to do it. And so we couldn't hire our own, we couldn't have our own physical location in terms of a whole gym setup, occupational setup, a whole social worker setup. And so we really needed to come up with a different way to do this. And so this is where the care coordinator plays a central role, and her job really is to try to sort of outsource and know what services are available to people. And the whole idea behind this really was to improve patients' quality of life who have Parkinson's right now. And so where are we with this project? Deanne, we're going to see a very beautiful picture of Deanne. Deanne is hiding in the back here, so she's our care coordinator who's taken on this position. So this is a very complicated job and required somebody who has a lot of expertise in the field. So luckily, Deanne was very accepting of this and has taken on this job full force. So she's had to do a lot of work in terms of getting this idea off the ground. So we have a database that we've created, and she's added to it in terms of what are the services that are available in the Ottawa region for people with Parkinson's. And this is not just, the Parkinson Society. This is, what physio clinics are here, which ones have some expertise in looking at people with Parkinson's. We had to look at, she wanted to make sure we had better links to family medicine services, geriatric services, psychiatry services. So she's gone out and met people who provide services for people, and her job is to build these links. And so not only has she done this, she's also sort of standard links that are there. So, community care access programs that are available, those through the city, whether it's swimming classes that happen. And so she's really done a lot of work to get herself up to speed on all the different options. With this database that we've created, she's also added the idea of making, are there adaptive or equipment needs that people would want to investigate. And so she's also added this kind of information to the database. Within the database, we can search for where somebody lives and try to find, obviously, services that are closer to them. We try to look at the different types of services somebody might want, and obviously what the names of those services are, and the ability to then give a printout after Dan's met with people of what are the options that people have. Here's their contact information, here's the website information, and so people can do a little bit of background. The other part of it is the cost, and so these services are not just all government funded. So some of them are private services, and the idea of what are the potential costs you're going to incur when you go talk and meet with these people. So one of the things as we're building up this program is we want to look at making sure that it's a viable program for the long term. And so the initial part of getting going has been funded by the University Brain and Mind Institute, as well as our Parkinson Research Consortium. And so, how do we study this in a comprehensive or in a way that we can show that there's benefit? And so people who come into this program are going to undergo sort of a standard battery of sort of Parkinson assessments that, for those of you who come to the clinic, already undergo most of these. Doing some cognitive screens on people, doing some quality of life screens, as well as looking at caregiver burden. And because that's obviously an important part of Parkinson's care is the caregiver. And then look at some clinical goal improvement scales when people come back. So what she's done is she's created sort of a personalized care map. So people come into the clinic, she's created a sheet where people try to identify, here's my 3 areas that I really want to focus in on, and then she tries to build, okay, how are we going to make your life better in those areas? And so that's really what she's concentrated on. She's going to then follow up either by email or phone call within a couple of weeks of seeing the person, and then we'll see them back in the clinic within 3 months to see how things are going. The nice thing about having Deanne in this position is that she can also, she's a rich source of information in herself. So making sure that she'll go through the medications, and are there issues with medication timing that she can identify that maybe tweaking the timing of pills can help. Looking at mobility issues, and are there any other things that can be done, talking to the physicians as well in terms of trying to improve mobility during those times. But she's providing education on those autonomic things, the blood pressure, the constipation, and tip sheets on how to manage those things. So she's definitely part of the care team and not just a person who's going to be referring. So who are going to be candidates for this care network? And we've done a lot of work and a lot of thinking. We've had input from individuals from our advocacy, patient advocacy, of which I see a lot of them congregated in the back corner there, who've been very helpful in bouncing ideas off of, is this the direction that we really should be going in? And so, as we're getting going with this program, we've decided to look at focusing on people who are more in the sort of moderate to advanced stages of their Parkinson's, and we do that for a few reasons. As soon as you make a statement like that, you're like, well, who is moderate and advanced? And it turns out in Parkinson's disease, it's not as straightforward to define that. So we're going to look at people who have had a diagnosis of more than 5 years, are not in an advanced care type of facility, they don't have really significant cognitive difficulties, or they're having a lot of trouble with motor and non-motor fluctuations in terms of how they're doing. And there's been a lot of discussion about, would this kind of program be helpful for people who are just diagnosed with Parkinson's? And the feeling is yes, but I think this kind of program may be better suited for people who are in these more advanced stages. And this in part comes from evidence in the literature. So there was a study just published 2 years ago in a very prominent neurology journal, and it was looking at an integrated multidisciplinary care program that they launched in the Netherlands in the mid-2000s. And they randomized people, actually 300 patients, to either get this integrated specialty care or standard of care in one of the hospitals. And so the disappointing part of this study was that they really couldn't show that there was any benefit. The patients who got this more advanced integrated care didn't seem, on the standard measures that we use, didn't seem to show any benefit. So the question is, well, why not? One of the issues that came up is who were the patients who went into the study? On average, they were patients who were there they only had Parkinson's for 5 or 6 years. They didn't seem like most of them didn't seem to have any significant mobility issues. Where 75% of them were in the earlier stages of their Parkinson's. And so the feeling is that in those early stages, we're doing a pretty good job, I think, at managing certainly the motor symptoms. So the medications that we have work quite well. And so the focus of this integrated care, and this is why we're looking at the more advanced patients, is in part because of this study. So far we've had 8 patients with moderate to advanced Parkinson's go through this, and looking at what sort of things has Deanne been able to do in terms of helping with their care. And so she's not only provided the direct counseling to patients, she's been able to link them to the Falls program, to some day programs that include some of the cognitive day programs, looking at trying to get additional CCA's community care access support for individuals. There are now private agencies and private companies that can actually help seniors in terms of transitioning in, whether you're moving out of your house, whether you're trying to change how you're doing things. And there are services through these kinds of agencies. And so she's helped link some people up with these types of programs. Obviously, we're trying to build very strong links with the Parkinson's Society of Eastern Ontario and making sure that all of those programs people are aware of and are accessing those. The speech therapy options that are available in Ottawa, as well as she's been very involved in, as I mentioned earlier, checking out some of the private physiotherapy clinics and making referrals to those specialty clinics who really have tried to get more training, specific training in Parkinson's physiotherapy techniques. So the other half of what she's been doing is also linking into some of our programs, and so our research programs. And so it turns out that one of our big programs, or our big research programs right now, is sponsored by the Ontario Brain Institute. And Ottawa, I'm proud to say, is the highest enrolling centre in Ontario for people with Parkinson's, based in part on Deanne's hard work, as well as our other coordinators. We are also the largest enrolling study centre in Canada with the caffeine study that's now ongoing, that was initiated for Mon Posthumus Clinic in Montreal. We also, Dr. Mestre has been involved in setting up a drooling study and an MRI scan biomarker study, and this is just getting going, and this is where Deanne has also been playing a role in helping us getting going. Dr. Meister's also taken the lead in another very exciting study that also came out of the Parkinson study group. So Dr. Schlossmacher mentioned this group with the adenosine study. And so this is another study looking at a calcium channel blocker that we're hoping is going to have an effect on disease progression. We also have another clinical study that's just going to be starting up for individuals who have more complex motor fluctuations with their Parkinson's, and the idea that you can take a puffer or a shot of your levodopa by an inhaler to get on faster. And so this is another clinical study that we're excited about, that we're hoping is going to really make a difference in people's lives with Parkinson's. So where are we going from here? So the clinic is, and this integrated Parkinson Care Network is really just getting going now. So we're really trying to roll it out now into the clinic, so individuals who come to our Parkinson clinic at the Civic will have access to this, and then are going to be booking separate appointments to see Deanne to work through this. We're looking at trying to extend this idea into what's called the e-consult service that's now running in Ottawa, where you can make referrals to different subspecialists, and the idea is that you can get a feedback, you can get an answer from these specialists within 2 weeks instead of having to wait 10 months to go see this particular physician. And there's also the idea that they're starting, and we're starting to explore this, is can you do this in a more comprehensive way with people with complex problems? So you have what's called an asymmetric integration of their care, where you might have a psychiatrist who's involved in inputting information through this e-consult mechanism. You have the neurologist inputting things, maybe the urologist, and trying to come together sort of on the web to come up with better care for individuals. And so this is something we're looking at now. We're also hoping this fall to start a study of the clinic itself. So does this new integrated Parkinson Care Network make sense from a cost standpoint, as well as showing that it really does improve care, with the idea that then we can go to the government and say, you need to help fund these kinds of physicians, not only here in Ottawa, but across the specialty clinics in Ontario. And I think I'll stop there. Thank you.
Thank you, David. I'd like to thank our speakers. They did a wonderful job at updating us on what's going on in the field and also here in Ottawa. And what I'd like to do is to ask them to join us up on stage and be available for questions that you may have. Here's a golden opportunity to actually talk to the people here. Yes, Adam. Okay, great.
I was very impressed, Dr. Brands, with the work that you're doing for the integrated care and the work that Deanne is doing. And I'm just wondering if you're planning to put something maybe on a resource list on a website for people maybe who don't qualify to be part of that program, but that could be directed to other resources in the community that could be very helpful.
Yes.
We get a restatement of that question.
Yes. So the idea is
I didn't hear a word of it.
So if we have is there the option of, if we have a database that has all this information that other people might find useful, can we basically share that database? And I think that's something that we need to look at. And I think it definitely makes sense. And I think there's not a big reason to restrict it. So I think we'll have to look at how we can potentially to download a database. We might be able to get it. We do have a Parkinson Research Consortium website up already, so maybe we can look at ways to do that. I think part of it will be that this is, it's currently in an access database. I guess we could put it into a spreadsheet so that people can look at it that way. But it is, yeah, I think it's a very good idea.
Yeah, question for Dr. Schlossmacher. I have Parkinson. I've had it for 3 years, but I also have elevated uric acid levels. And I guess I had a gout attack back in November. And they wanted to put me on colchicine and allopurinol. I said no, because I had read that there is some antioxidant effect for uric acid. So what's the consensus now? Should I treat this thing, or should I leave it, or is there value?
So first of all, so the question for those of you who may not have heard this, when people do have gout, are they eligible, or should they participate in the study, or should they take the drug to potentially manipulate the uric acid? So number one is, I'm very sorry that you had painful, because it's usually very painful to have gouty arthritis. Number two, you don't want to further elevate it, so I would not suggest to be enrolled into that trial, because the elevation is modest. I think it's 10 to 20% maximum, but if you're at the borderline of having gout or not having gout attacks, you really don't want even a picomole more elevation in your uric acid. But what we don't know is actually what is the long-term effect of manipulating the level, and how long does it have to be slightly elevated to confer benefit. It could be argued that because people have a higher antioxidant effect, the whole process of the disease is slightly different. And unfortunately, only long-term trials, like phase 4 trials, will ultimately answer the question as to for how long do you have to manipulate the level, and who is potentially benefiting from it. Does everybody benefit from it, every type of Parkinson's? And all of these questions are going to be answered. So I think, unfortunately, in your case, you don't have all those answers yet that you want to know. But having seen people suffering from gout, it's very painful. I would not want you to suffer from a medication, from a treatment intervention, where we don't have all the answers yet that inflicts pain, and therefore I would be very cautious on a person-to-person level when they have a history of either already elevated level, or have a family history of gout, or are prone to, because of other conditions, to have gout in the future.
The brain donation form that you have for people who want good brain applies only to your patients, whether some of your of your patients do if you want to get a brain. After death.
So, I mean, it's important a technicality, and so if you have been seen at the Ottawa Hospital, the cost of the autopsy itself is free. And so if you've never been seen at the Ottawa Hospital, and then you want to do the brain donation part, the Ottawa Hospital then will charge its many thousands of dollars actually to do an autopsy. So we've been able to wiggle around this a little bit, that if somebody even, had a urology consult 15 years ago, we sometimes can kind of sneak that in. Certainly our pathologist is very much on board in terms of if somebody wants to donate the brain, even if they haven't. So we can try to find some wiggle room, but you really have to have had a record, or then the administrators come after us and say that, no, this patient really wasn't a person in your clinic. But really, that's what they want is to be, really make sure they're part of the clinic, but we have been trying to skirt it a little bit. But and it's really just a cost issue. For it.
I think if I may just add, although many people think this is an awkward discussion to have with doctors or nurses or family members, we found that it's actually really addressing issues that are very, very important to people that are affected by it, and sometimes you just have to break the ice. So if anybody thinks about it, I think it's just important to talk to the general practitioner or to other healthcare providers to get into the system, because as David said, it takes so little to get into the system for a small procedure, a small test, or a small doctor visit that will allow you in the future to benefit from it. So I think we're trying to approach this topic more and more because we hear from the people that they're actually very interested in
providing more information to their loved ones, and also addressing the issue, as Andrew Frank said, can we learn something about the potential heritability? Is there something that tells us this could potentially be passed on versus not be passed on? So sometimes it's just breaking the ice and talking about it to people in the healthcare system. There was a question in the back there.
Dr. Grimes, the integrated care study you're working on, what were the evaluation what do they use as evaluation metrics for the Dutch study? Are they using the same ones? Are you using anything different to measure?
So when you look at the forms, a couple of forms looked like they were Dutch. So that when you looked at the actual name of the form, it wasn't English. So that was, but I think they had a caregiver burden assessment, so we're just using a different caregiver burden. They did use the Unified Parkinson's Rating Scale, which is sort of a worldwide accepted rating scale. I think they were still using the older one, but I'm sure they're now going to be using the newer one. And so the assessment tools they looked at were similar. And so I think your question is going, are there different ones that we should use to try to get a better outcome? They did, they used the European version of a quality of life scale. So we're going to be looking at the full version that I think is used more commonly now as a quality of life scale. So hopefully we'll be able to tease out some better things from that standpoint.
Yeah, quality of life is one of the things I was wondering about. In the burden of care, was that a validated scale or something that they made up themselves?
I didn't look specifically into it. I didn't recognize the scale itself. It looked like it was potentially more of a Dutch kind of scale, so I don't know how validated it is. But we're using a general, not even Parkinson-specific caregiver burden scale, so it's a more global scale that's used in other diseases.
I will just add that when we had to decide between the different scales, we actually have the fortune in movement disorders in the Parkinson's world to have, so there's a movement disorder society, and within the society there's a number of initiatives analyzing different rating scales available for the different symptoms of Parkinson's, and we try to use the ones that have been actually recommended for Parkinson's disease research.
Look at the back.
I'm an example of success. It's hard to define success because the models we use are you better than you were yesterday? Where are you going? Is this rehab? Is this something new? Are you going to be, am I going to be the star I used to be? The question of success is that do I live happily now in a community that cares? And the answer to that is yes. If you'd asked me a year ago, I was in a wheelchair for a different reason. I was in a wheelchair because I was losing my everything. My dopamine wasn't working. Then I asked for the deep brain activity. And I was told it wasn't appropriate for me. And so instead it was suggested that I might try to do a dopa. Put a tube into my tummy, into the small intestine, and distribute the dopamine into that area where it goes to my body consistently. So every morning, every night, I take this off, my wife does, and then in the morning I put it on again. I have a death and a resurrection every day. I'm very happy that there are people who are looking after the money part. You need to do more. I'm happy for the doctors who are doing the thinking part to find a solution. You need to do more. I'm very happy for the caregivers the community of people that make it worthwhile. And you have no idea how important that is, that we feel like we belong to others as well as ourselves. Because the thing about having Parkinson's is that I'm getting less and less and less. I used to be a very good speaker. I can sometimes come up to the standard now, but not very rarely.
And you're a good singer.
Yes.
So thank you. Thank you for your corner of our community. Thank you for putting yourself into it, because I'm losing my power and I need you to take over for me. And so I'm very happy that Ottawa has doctors who are willing to talk. And this is remind you to take my other pills.
Thank you very much, Nick. There was a question over here in the back. No?
How the pollution of water, air, and even in your food. I heard recently that even in the tea with rice, you can find a certain percentage of arsenic. How this can affect our health and the good health of the brain on long-term basis.
I think when you look at, what, if we bring it back to Parkinson's, we know what causes Parkinson's disease. When we look at sort of the environmental impact that factor that we think plays a role in potentially inducing Parkinson's, we still think that that environmental impact is, for most people, still relatively small. We know there are certain risk factors, certain pesticides, where you live or where you were brought up can play a role in increasing the risk of Parkinson's disease. But I think when you look at individual chemicals and say, I took this or I was exposed to this, am I going to get Parkinson's because of that? And I think the answer for most people really is no. And so for most of these kind of potential toxic chemicals that are in our environment, our ability to hash out that those really are really bad for us is very difficult, and I think we still need a lot more understanding of this. And so, again, for the individual person, it makes it very hard to know what these toxic exposures might actually mean. And I think we just don't have the answer for a lot of it.
And it's also difficult because when you look retrospectively at these patient populations, you don't know really what their level of exposure was. So in a lot of cases, it's extrapolation from their past history, where they on the farm, et cetera, et cetera. But it's hard to correlate exactly what's going on. Yes?
A question for Dr. Sachs. At what stage in disease progression were the patients that were operated on and received DBS? And what are the current criteria to determine if it is applicable to perform DBS?
So Dr. Sachs is not here, so you'll have Tiago answer.
So the question was, basically, what are the criteria for patients with Parkinson's disease to qualify for deep brain stimulation? And so, let's say I'm the neurological part of the DBS program. And so we do assess the patients and we do the post-operative programming that's required to obtain the critical benefit after DBS. But in a few words, so DBS is the indication for DBS is for patients that have started to have what we call motor complications. So both either they develop involuntary movements when they are under the effect of the pills, or during the day they'll have successive periods where they experience the benefit of the pills, and then periods where the Parkinson symptoms reappear. And adding to that, although it's changing, also we are not able to manage it with pills. In these concepts now it's more flexible. mainly because of a trial where patients that just had started to have multiple fluctuations and dyskinesia were submitted to a trial. They had DBS, and it proven at least after 2 years it was very effective and had an impact on the quality of life of patients. So the flip of the coin is, what are the patients which we are more cautious, and many times we have to contraindicate or discourage DBS. So one of the main points that we look for is cognitive function. So patients that have a significant cognitive impairment usually are not considered good candidates for deep brain stimulation. And more as a relative contraindications, patients that have acute significant psychiatric symptoms such as a major depression, acute psychosis. Those are not absolutely contraindicated. They will have first to treat well these psychiatric symptoms for to be considered future in DBS. And then one final that it's often brought to discussion is age. So usually we use the cutoff of age 70, but we go much more by what we try to determine is the biological age of the patient. So it's considered, it's a soft criteria, and it's not because of the patient has turned 71, 72, that's why we'll not consider for a deep brain stimulation.
As that sort of a corollary to that question, we always talk about the benefits of DBS, but could you maybe talk a little bit about potential risks of the surgery? Is it a major factor? Is it not a major factor?
That will be better for Dr. Sachs to explain, but usually it's really not. I mean, the risks exist, and the major risks I disclosed from the surgery, although usually Dr. Sachs will approach those risks, are the risk of infection and the risk of having a bleed in the brain. Okay? But usually the risk of a bleed that's severe, for example, it's 1 out of 100 patients that undergo deep brain stimulation. And then of course, with stimulation, there's side effects related with stimulation that usually we can overcome by tweaking the stimulation, but it's also something that we have to disclose, such as speech impairment or even walking difficulty. So DBS can work both ways, can help patients walk better, but by itself can be associated with walking difficulties.
Thank you. There is many different potential strategies for addressing some of the quality of life issues for Parkinson's that may be not traditional in the sense. Do you think that there is a better mechanism, or should be a better mechanism, to kind of evaluate those alternative approaches that might exist for brain disorders like Parkinson's?
I mean, there has been, there are lots and lots of different therapies that are potentially helpful for people with Parkinson's, and it is very difficult to sort of which ones really might be a benefit and which ones might not be a benefit. And so this ties back, I think, into the science of trying to understand things and really if they really are helpful. So we do have to be very careful of how we design our research studies to make sure that we're really answering the question, because we know that no matter what we do, that up to 30% of people will feel better no matter what the intervention is. And so you're always looking at the placebo effect of whatever your intervention might be. And so I think it's something that people are exploring more. I mean, I know there's a physician at the Ottawa Hospital who has a very large grant who's looking at alternative care in cancer patients and what those types of therapies might be. But there are so many out there, it makes it, there's almost an infinite number of them that you really almost can't keep up with the latest one and whether it might be helpful or not. I think the biggest thing is you just have to be, I think, cautious of many of these alternative therapies in that you just need to understand that they're not proven for most of them, and that you know, I think the biggest risk for a lot of it is your pocketbook. But are some of them going to be helpful for people? Yes, I think so. But which ones? I think that makes it even harder to know the answer for.
Perhaps one more question, or two more questions, three. 1, 2, 3.
Can any of you comment on the theory that work is being done on gut-brain connections and some of the bacteria that got their information in the gut that could affect some diseases like Parkinson's?
Michael would be the perfect one.
Seeing Dr. Schlossmacher won an award this last year for his work in that area.
The best pending research paper.
That was awarded to Dr. John Wu, who led the team. That's a very good question. So the issue was, what's the relationship between the gut and the onset of the development of Parkinson's disease? And the information came from that couple first that I showed Dr. Brock and his wife, Dr. Del Frenchi, who published the idea, not just the idea, but very important data from human patients that came to autopsy that revealed that a lot of this aggregation of alpha-synuclein, which is this bad player of Parkinson's, may have in about 78 to, some people argue about the 78 to 85% of the people, there's this evolution of changes that begins in the gut and ultimately makes its way over a course of 25 to 30 years all the way into the forebrain. And the people that don't meet those criteria and where it cannot be found to have to take that route, it actually seems to initiate from the nose and making its way into the back of the brain. And that's one aspect. The second aspect is that people, gastroenterologists, have told us that over many years they've observed that people with Parkinson's not only have constipation but also have a higher risk of having irritable bowel syndrome, and there's a few cases that of people that have inflammatory bowel disease, such as Crohn's disease. Then comes also an observation that genetically there's a link between Crohn's disease, which is an inflammation of the bowels, and Parkinson's. So one of the key genes that we study is linked to both conditions genetically in large population studies, which led in part to a large grant from the government of Canada that Dr. Park, myself and 5 other colleagues received to study this aspect of inflammation further. So there's definitely something there in terms of the initiation. My own feeling is that, and again this is not yet proven, but that's what we're testing with this grant, is that we've spent so much money and so many years on the notion of toxins and contaminations in our food or in our soil and in our milk and God knows what, but it hasn't been proven to be making a really big contribution, as Dr. Bryan summarized. My feeling is, because it's true now, even rheumatoid arthritis, that what goes on in your gut, the bacteria and the viruses that live there, how they interact with the immune system, are now more and more known to play a key role in the development of disease. And rheumatoid arthritis is now one of the most striking examples. Nobody would have thought that the gut has anything to do with it. But a series of papers from China to Europe and America have shown that what lives in your gut determines whether you're at high or at low risk of developing rheumatoid arthritis. So many people now start to test this idea. What lives in your gut, does it have a beneficial or detrimental effect on your ultimate risk to develop Parkinson's? And this is also actually being done now in multiple sclerosis. So there's many, many studies all over the world in different diseases that take the third genome, namely that the makeup of your gut microbes, the viruses and bacteria in conjunction with your own DNA and the mitochondrial DNA, to put this all together and see how that plays a role. So that's a long answer to your short question, but I think it's one of the hottest, potentially most satisfying avenues that people pursue now around the world. Why is that important therapeutically? Because we also know that we can change the gut flora. It's also one of the hottest topics in diabetes and in obesity research. People have now shown that if you take the flora, the gut constituents of mice that are obese and put them into lean mice that are genetically identical, within 3 months you make the obese mice lean and vice versa. So what lives in your gut has an enormous contribution on the risk of developing disease in various organs, and not just joints, but brain and adipose tissue.
Thank you, Michael. Kevin.
Yeah, I guess a question for Dr. Grimes. What would somebody do if they want to get involved in a clinical trial or look into getting involved in a clinical trial?
I mean, I think there's a couple different options. I mean, certainly, you know, when you look at the web, there's like the Michael J. Fox website, Trial Finder is trying to link people up. Certainly, coming into the clinic, we're trying to keep people who we see in the clinic, seeing if they're potential candidates when they come in. Part of Deanne's role is to also reinforce these potential patients who she's seeing. Are they candidates for any of the research that we're involved in? So I think there's a few different avenues. I think more and more we're seeing that patients are identifying studies on the web and then contacting us and saying, listen, could I be a potential candidate for this particular study? And so I think that road is happening more and more. So I think there's many different options.
And I would just add that we also locally we have adopted that line. So currently the MRI study that Dr. Grimes mentioned, and in short time also the study on healing for Parkinson's will be in the Michael J. Fox Trial Finder. And in our experience has been that since, for example, the MRI study, we've got a lot of interested both patients and healthy controls that want to take part in research. There's definitely some sort of tool.
Yes, for Dr. Schlossmacher. You mentioned the alpha-synuclein blood level and the correlation with the cognitive function. I mean, why is it when you have low alpha-synuclein in the blood, you have a lower cognitive function?
We need people who are as inquisitive as you are. Do you want to come and work with us? So that's a very good question, because normally when you have too much of this protein, either for genetic reasons or others, you can promote and develop more severe Parkinson's and dementia. This is why we couldn't get this work published, but I think there's a really intriguing constellation, and it's actually the mirror image of what we find in the spinal fluid too, that there's, even in people who have never seen a drug for Parkinson's, they already have a slightly 15 to 20% lower level. So what matches, what goes on in the blood seems to match the spinal fluid. And I begin to think that this is like a sigmoidal curve. So this is a curve with two ends. And if you have a very low level, it may actually put you at risk. I think it's a risk marker. And that maybe what happens to the host, to us, when we encounter environmental stressors, I think that upregulates it then, and then we make too much of it in some cases, and that promotes disease. So we're testing this idea now, because otherwise you can't reconcile everything that's out there. And because it's been proven in multiple beautiful, bias, but in multiple really important cohorts where we look for every single variable and it just stands the test of time, we think this is a true finding from collections of blood around the world, all done under the same protocol. So to find the biological explanation for this observation, I invite you to come and work with us and bounce around ideas and test them. But I think there's a critical clue, and to just dismiss it and say, oh, it's just chance, is not the right answer. I think there might actually be an opening to understand how the beginning of the disease unfolds. And many of those people who had this low level, they were very early in their illness. They didn't have drugs yet. They had the disease for 2 years. And we proved it with brain scans in some of them, that it really was Parkinson's.
So is it accumulating in the brain instead of staying in the
So
brain?
that's a good question. We don't have yet the autopsy proof, because these subjects were very early on in their illness. And the longest we followed them was for 5 years. And we couldn't take brain biopsies, but they met all the clinical criteria that are currently being applied. So it's a mystery, and sometimes in science we go into experiments, we're very biased based on what we know. But when something comes around that throws us off, we can't ignore it, we have to pay attention, and hopefully within the next 2-3 years we'll have the answer, because we can test this now in animals.
Okay, so one more question with Nick at the end, and then a comment.
As we come out of the closet in Parkinson's, and we gain some comfort in the motor descriptions, I request that as we come out of the closet in the non-motor descriptions, that we use the words more carefully, words such as dementia, because it frightens a lot of us, and delirium, and the ostracization you feel by some of them. I feel that the words we use about the progression is not, I mean, do we want our Parkinson's to progress or do we want it to regress? The words about, words that minimize things. Do the symptoms of Parkinson's, do we want to improve the symptoms? No, we want to improve the going away of the symptoms. So we're not consistent in our language yet.
Thank you very much. You had a comment in the midst of all this noise to make?
I just want to say thank you so much to Natasha and everyone who organized this event. Last year, I came to this event
go ahead.
Last year, I came to this event, and a friend invited me as a guest. And at that event, I spoke to Dr. Grimes about my husband, Arnold, who has recently been diagnosed with Parkinson's. And he asked me if he was on medication yet, and I said no. And he gave me Dr. Mestre's name. And we contacted Dr. Mestre in the office, and now my husband Arnold, I think, was the first person in Ottawa to sign up for the trial that Dr. Mestre's doing. And I just want to say how grateful I am for what you're doing, the commitment that you have, the personal relationships that you develop, and the impact that it has on our life is tremendous, and it gives us so much hope. And we want to thank you so much.
If I might ask a question, and that is, in practical terms, with the Integrated Parkinson's Care Network, if you are a person with Parkinson's who is fortunate enough to enroll, I kind of envision that one of the best benefits among many is that in fact they have better access to your care, either through Diane or through in conjunction with Diane and to you as well. So is that part of the goal of the IPCN? So because we all know that the clinics are very, very busy, and it's maybe once a year now. Is that
I mean,
you guys know better than me.
Yeah. That's definitely. I mean, a recognized problem is that there's only so many hours that we all have in a day, no matter what we're doing, and unfortunately, the wait lists have gotten way too long. So that is one of the things that we're trying to build into this care network is a way to provide better care with the limited number of spots that we have. And so definitely, Leanne is trying to enhance that communication piece, and so that there is more potential for interactions. I think the other part you can see is that within the clinic in Ottawa, where we have more neurologists who are running and being a part of the clinic. And I just let you know that some of you met my fellow from last year, or our fellow from last year, Chantal Brett, and she's going to also be joining as a staff movement as a neurologist, and she'll be coming into the clinic once a week as well. So we're hoping with building the number of physicians as well as our integrated care program that we will be able to provide better care and better access to care.
Great. So with that, we're going to end the evening, but before you leave, there is additional food, I believe, that's been put in the back. And before we go there, please, I urge you to all stay and talk to us and the researchers and the clinicians. We're really here for you. But I do want to say one more thing that's a little bit different than what we've heard with our expert panel here, and that is, I think it's important for me to talk a little bit about a theme that Nick introduced, and that's the concept of happiness. So really quickly, when you said happiness, I thought of when I was a teenager, how I had this argument with my mother, who was telling me what to do in life, and I said to her, "Don't bother me, I know what will make me happy, because that's very important to me." At which point my mom looked at me and said, you know, "Dave, life isn't all about happiness." And I never really knew what she meant by that, until maybe quite recently, having worked with many people in the community, And I think what she meant by that was, of course, that you will have profound moments of happiness in the journey of life, but of course you will have profound challenges as well, challenges which I'm sure all of you are intimately, as we all are, aware of. It's a long way of saying that, in fact, we knew of a woman, Sharon Pickle. Okay, Sharon Pickle, who, in fact, was an extraordinary woman who faced those challenges with fearlessness and courage. I've had the pleasure of knowing Sharon for a couple of years now, and perhaps some of you in the audience knew her as well. She was a strong supporter of what we did. She was always there, always volunteering, always energetic. She had this fierceness within her, cocooned in generosity and love. We lost Sharon this summer. We'll miss her tremendously. And I don't want to make this too sad, but I do want to make this a celebration of who she was, what she meant to us, her support. Sharon, I met Sharon because she volunteered for Lap the Gas. And she, in fact, the first year of the event, actually did a full gap loop. It was quite amazing, given the fact that she really didn't think that she could have done it when she first started training with us in spinning sessions. And that characterized Sharon. She had this courage that was second to none. And so I want to kind of commemorate and celebrate who she was. And about a year ago, I asked her to participate in a film about the brain and mind, which she did. Most of you have probably seen it already, and I'd like for us to maybe view it again in light of Sharon and what she meant to us, because she is the woman in there who will be the yoga instructor. And really, I think the message embodies what Sharon was all about, and what, in fact, we are here with the Brain and Mind and the Parkinson's Research Consortium to try and have this courage, make the journey better, and with that, celebrate Sharon's life. So if we could have the video one more time.
Our patients are strong. Every day they live with neurological disorders such as Parkinson's disease, stroke, depression, and ALS. And every day they fight to maintain their quality of life.
But they can't stay strong forever. Seulement une recherche novatrice, ainsi que des soins cliniques à la fine pointe de la technologie, peuvent les aider. We are here to make it happen. Par une meilleure compréhension de la complexité du cerveau, nous pourrons découvrir son aptitude à s'adapter, à changer et à guérir.
Together we will reduce suicide by 20% by the year 2020.
Personalized Parkinson's care.
And eliminate the effects of stroke.
Thank you very much, and please stay. The air conditioning is back on. Enjoy the food in the back.